I need you to imagine, before I even begin the lecture, I want you to think and use your imagination to develop a mental image of a set of things. And the first thing I want you to imagine is that behind me, running from floor to ceiling, from right wall, your right, to left wall, is an orange elastic membrane. Complete, floor to ceiling, one wall to the other. And in front of me, at the level of this first row of chairs, again, running completely from floor to ceiling, completely from one wall to the other, a blue elastic membrane. And I'm stuck between the two at the moment, but then a row behind that, running from floor, but only, from ceiling to only about a third of the way down, but completely right to left, a brown elastic membrane. And the row behind that, running from ceiling about halfway down, completely right to left, a brown elastic membrane. I'll repeat these for you.
Okay.
And the row behind that even, now again, completely, ceiling to floor, wall to wall, a gray elastic membrane. All right, now what we've got here, complete orange behind me, complete blue in front of me. Next, in front of that, a brown that comes a third of the way down. In front of that, a brown that comes a half the way down from the ceiling. In front of that, a gray that is complete. So we have 1, 2, 3, 4, several membranes. Now, I'm sitting here, standing here, between the blue one and the orange one. And all around me are these yellow Nerf balls, all right? And so I'm completely surrounded by yellow Nerf balls, except there's also a purple balloon here, and a rope and a bow and arrow. It's going to make sense to you. So I've got a bow and arrow, a rope, a big purple balloon. I'm going to take one end of the rope, and I'm going to unravel it so it splits into two things, and I'm going to crazy glue one end of the rope to the balloon, purple balloon, and one end of the rope to a spot here on the orange membrane. So now the rope comes, it splits, one end goes, one strand, if you will, goes to the balloon, one strand I've crazy glued to the spot on the orange membrane. So I take the other end of the rope, and I attach it to my arrow, and I stand here with my bow and arrow, and I ask the woman who's using the computer, the Red Apple computer, to stand up. Now, this is a difficult and dangerous task, because I'm going to shoot this bow to you, get in the right place, and I want you to catch it when it gets there, okay?
Catch an arrow.
Good. All right. Now, your roll is not yet finished. Your roll is not finished. So, she's got this arrow, and now she's got the rope that was attached to it, and of course that rope went through a hole right here in the blue membrane. It went underneath the shorter of the first brown membranes. It just clipped the lower edge of the second brown membrane, and then it made a complete hole in the gray membrane. Of course, the hole in the blue ones was here, and then it went underneath the first brown one here, and then it clipped the bottom of the second brown one here, and then the hole it made in the gray one was here. So they are positioned obliquely across the room here. Now I need you to pull on the rope. All right, fine, very good. You're not finished yet. So she pulls on the rope. It pulls out a tube from the orange membrane, and it pulls the purple balloon. And this tube from the orange membrane, lying next to the purple balloon, encounters this hole in the blue membrane, which is very small. They are too big to get through that hole. So continue to pull. She continues to pull. They pull out a tube of the blue membrane ahead of them. And you continue to pull, and that now tube of blue membrane surrounding the tube of the orange membrane, which is adjacent to the purple balloon, gets pulled in beneath the shortest of the brown membranes. And as you keep on pulling, it encounters the hole in the bottom edge of the second brown membrane, which came halfway down, can't fit through that hole. We've got this big blue tube surrounding an orange tube lying next to a purple balloon. So it just starts to pull out the lower edge of that second brown membrane. And then as you keep on pulling, you pull all the way to you. It goes, meets the hole in the gray membrane, much too small to get through, pulls out a big tube of the gray membrane, and now she's got this rope, and that rope is attached to a tube of gray, which surrounds a tube of brown, which is from the second membrane, which surrounds a tube of blue, which surrounds the tube of orange next to a balloon. Okay, you can sit down. You did a very good job. Now, the lecture. Not obvious what the link is here. We're going to be starting a dissection of the abdomen today at the stand where I won't be in people's way. And this is a schematic cross-section of the abdominal region of the body. You know that the outermost layer, you knew this from day one when Dr. Larson gave her lecture, the outermost layer is skin. I've indicated epidermis and dermis here in different colors. Next, beneath that is the subcutaneous layer with a lot of fat in it, and many people, most people, some fat. Deep to the subcutaneous layer are the muscles, bones, and fascia of the body wall of the abdominal region. And I've labeled a few of them. The epaxial muscles of this region you know about, and then there are some hypaxial muscles. I haven't drawn in latissimus dorsi, which is a hypaxial muscle that migrates in between the epaxials and the subcutaneous layer. But I've shown all the other epaxial, hypaxial muscles of this region. Psoas major is a muscle of the limb. We don't really need to know much about it today. Quadratus lumborum, a hypaxial muscle of the abdomen. But the ones we do want to talk about today and spend most of the time on are what are called the anterolateral muscles of the abdominal wall. These will be dissecting these today. And they're a big sleeve of muscle that wraps around the side and front of the abdominal cavity. The interesting thing, one of the interesting things here is that the fascia which lines the anterolateral muscles on the inside, the deep, is split into two layers. One is the inherent deep fascia of the in gray of these muscles, but there's a separate fascial layer, even deep at that, which is called the transversalis fascia. And you can pick it up if you're really careful. You can pick it up and separate it from the inner surface of these anterolateral muscles. And then those muscles surround, with the transversalis fascia, surround the body cavity, which is not unlike the cavity of the chest, but it's in the abdomen. The body cavity of the abdomen contains a sac of peritoneum and the gut, which has pushed it from the back up into the cavity and dragged some, if you've done your embryology, or when you do your embryology of the gut, you'll see how this happens, and carries some peritoneum around it as well. And the peritoneum is divided into the peritoneum, which is in contact really, or at least right adjacent to transversalis fascia, and then adjacent to the quadratus lumborum and to the psoas and to the vertebrae. And that is called the parietal peritoneum. The concept of what a parietal layer of mesothelium, of coelomic sac is familiar to you, like the parietal pleura. Well, this is the parietal peritoneum. The peritoneum is the abdomen's version of the pleura. And then the gut has pushed through and pushed ahead some peritoneum, and where peritoneum encounters the actual, is adherent to the actual surface of the gut tube, that's visceral peritoneum, and the double-layered sheet which runs from the posterior parietal peritoneum to the visceral peritoneum of the gut is called the mesentery. All right. Most of this you probably already have a fairly good grasp of because it's not terribly dissimilar from the chest. The space that is encompassed by the peritoneum, by the parietal peritoneum, that is the space between parietal peritoneum And visceral peritoneum is the peritoneal cavity, and like the pleural cavity, and like the pericardial cavity, contains only fluid normally. You can say the peritoneal sac contains the gut if you consider the sac as the space encompassed by parietal peritoneum, but the peritoneal cavity contains only fluid. This space here, this space between parietal peritoneum and transverse salus fascia, or the fascia of these things at the back here, what would we want to call that? We want to call that the extraperitoneal space. Now, there was no space between parietal pleura and the endothoracic fascia. The endothoracic fascia is the chest's equivalent of transverse salus fascia. There was no space between parietal pleura and the muscular fascia or bones of the rib cage, but there's a considerable space between parietal peritoneum and the muscles and fascia and bones of the abdomen, and that is called the extraperitoneal space. And because anatomists love to give names to every conceivable thing they can think of, the part of the extraperitoneal space that lies anteriorly is called the preperitoneal space. And the part of the extraperitoneal space that lies posteriorly is called the retroperitoneal space. And I even go further than most anatomists and like to call the part of the peritoneal space which lies lateral to the parietal peritoneum, or laterally, the lateral extraperitoneal space. Actually, I've seen this. I thought I was the only person who did that, but I actually saw it in a clinical book once too, and I didn't cheat and copy it. All right, so extraperitoneal space, just give them names depending upon whether it's in front, behind, or to the sides between the parietal peritoneum, and the muscles and fascia and bones of the abdominal wall. Now, in the retroperitoneal space, you will see in your dissection, if not today, then certainly later, are some major structures. The abdominal aorta lies in the retroperitoneal space. The inferior vena cava lies in the retroperitoneal space. The kidneys lie in the retroperitoneal space. And where there are no structures is a bunch of fat, a fatty connective tissue. So there's a lot of fatty connective tissue in the extraperitoneal space. Retro, less lateral, and less anterior. I haven't indicated less in those regions on this drawing, but it is more voluminous in the retroperitoneal space than in the other regions of it. Here is a highly schematic version of things in an embryo before the muscles and fascia have developed. I still got a coelomic cavity, which is our peritoneal sac in the peritoneal cavity. I've drawn the aorta in here, which in fact is always in this retroperitoneal space, even in the embryo, as is the inferior vena cava. But I've eliminated the kidneys from this retroperitoneal space because the kidneys don't develop in the abdomen. Kidneys develop in the pelvis and migrate into the abdomen later in development. You'll learn about that. And I put in some things which don't lie here in the adult, and these are the gonads, which form in the retroperitoneal space in the embryo and migrate out of it inferiorly. So I've had an exchange kidneys with gonads because of the different embryological origins and migrations of these structures. And I've indicated then the hypaxial dermamyotome cells, which are destined to become the anterolateral muscles of the abdominal wall. There is running from the gonad to the developing skin on the front of the lower abdomen a fibromuscular cord-like structure called the gubernaculum. And that gubernaculum not only runs from gonad to the skin of the anterior abdominal wall, but has a little attachment to the anterior part of the peritoneal sac. That gubernaculum exists in development prior to the development of the muscles from the hypaxial dermamyotome cells. So I've drawn it in here before those muscles develop. Now you know the hypaxial dermamyotome cells are going to start migrating around the side and the front of the body, and eventually they will reach the front of this abdominal region and stop their migrations from each side. But because the gubernaculum existed prior to their migration, a hole is left here for passage of the gubernaculum. So when these things turn into muscles, these hypaxial dermamyotome cells, when they turn into the anterolateral muscles of the abdominal wall, there's a hole in the fascia and muscles, and a hole in the transversalis fascia and the anterolateral muscles for passage of this gubernaculum, which pre-existed these muscles in development. Now, if I were to just suck out the gubernaculum from that space, I could call that space the inguinal hole. The inguinal region is this region just above your groin there. So I would call that space the inguinal hole. And I would know that it exists because the muscles and fascia formed around a pre-existing fibromuscular cord called the gubernaculum. Now, this would be very bad if this is how it developed in actuality, as I've drawn it, where I have the inguinal hole starting deeply and running straight forward to pass the gubernaculum out to the skin. Because if it really ran that way, and every time you increased your intra-abdominal pressure, it would press the anterior layer, or anterior region of the parietal peritoneum up against the entrance point to that inguinal hole, the deep entrance point. And that little parietal peritoneum could actually push through alongside the gubernaculum and push through that entrance point and could actually go all the way through the inguinal hole and come out the front. Now, when a structure pushes through a muscle abnormally, and this is true anywhere in the body, if a structure which is supposed to be deep to muscle pushes through that muscle and ends up superficial to it, that's called a hernia. So this, in fact, would be a herniation of the parietal peritoneum through this inguinal hole as I have described it to you. And that's bad enough, but of course, with time, the bowel could just follow that little parietal peritoneum herniation, and then you could have a herniation of not only the parietal peritoneum, but of the bowel through the anterolateral muscles up of the abdominal cavity. So that's something you really wish to avoid if at all possible, because you will get into all sorts of trouble if bowel herniates through that. So what you do is, in fact, have the gubernaculum in development have an oblique passage to its attachment to the skin, so that when the hypaxial dermamyotome cells migrate, the hole that passes through the developing anterolateral muscles is not a straight and short hole from deep to superficial, but is an obliquely disposed hole from deep to superficial, and as I've drawn here. And if I suck out the gubernaculum, this is pretty long. And we could call it now the inguinal long hole, but we don't call it the inguinal long hole, just like the long hole between the Atlantic and Pacific Oceans through Panama is not called the Panamanian long hole. It's called the Panama Canal. And so we call that long hole. That's true, what can I tell you? That long hole through the anterolateral muscles and their fascia of the abdominal wall, the inguinal canal. And it exists because the gubernaculum had this oblique passage to the skin and the muscles formed around it. And now when you increase your intra-abdominal pressure, the back wall of the inguinal canal gets pushed against the front wall of the inguinal canal, just like a flat valve, closes the opening and stops things from herniating into it. So that is why it has this oblique path, so that it is much more difficult for things to herniate and pass through the opening, the deep opening, and run through it out to the superficial opening. All right, so now that is the history of, or embryologic history of why we have this long oblique hole in our anterior abdominal wall musculature. Here are the bones. We're going to talk and give names to the anterior abdominal wall musculature now and give in relationship to the bones of the pelvis, because they all have an important relationship and attachments to bones of the pelvis. So if you don't know this is called a hip bone. Each one, there's two hip bones, one right, one left. The top edge is called the iliac crest, that you do know because it was important in lumbar punctures. The iliac crest terminates anteriorly in something called, Dr. Larson told you, the anterior superior iliac spine. Here's the anterior inferior spine, but I don't care about that today. This bone, this hole, this socket for articulation with the Your thigh bone is called the acetabulum, which means little vinegar cup, because it looked like that to some Greek or Latin person. I don't know if that's Greek or Latin. And the ilium is the part of the hip bone that rises superiorly from the acetabulum, the socket for the hip bone. And then you have parts of the hip bone which pass medially, and then another part which passes down. I don't care about the part which passes down, called the ischium, but the part which passes medially from the acetabulum is called the superior ramus of the pubis, and it terminates in what's called the body of the pubis, which articulates with the body of the pubis from the other hip bone in what's called the pubic symphysis. And then there is something right here at the top of the body of the pubis, a ridge called the crest. I haven't labeled it here, the crest of the pubis, but the crest terminates laterally in a little bump called the pubic tubercle. So I'll have occasion to refer in this lecture quite a bit to the pubic tubercle and to the superior ramus of the pubis and to the iliac crest as well. Here is the first of our 3 anterolateral abdominal wall muscles. This is the abdomen's version of the external intercostal muscles. It is called the external abdominal oblique muscle. It arises from ribs, very much like an external intercostal muscle would do, but it's much bigger, obviously. It spans more ribs. It arises from ribs, passes obliquely downwards and forwards, just like external intercostal muscles do. Has quite a bit of muscular attachment to the iliac crest. And then, if you draw a vertical line from the anterior superior iliac spine upwards, the muscle fibers stop and give rise to this broad, flat tendon. And you know from your studies of the back, I hope you know, that broad, flat tendons are called aponeuroses. One is called an aponeurosis, plural is aponeurosis. It just means a broad, flat tendon, doesn't mean anything more than that. So the external abdominal oblique muscle fibers arise from ribs, insert partly into the crest of the ilium, and then largely, and most of them, yield way to this broad tendon, the external abdominal oblique aponeurosis. And that external abdominal oblique aponeurosis sweeps down along the front of the abdomen, and it has its lower edge, gains attachment to the pubic tubercle. Some of the fibers of the aponeurosis gain attachment to the body of the pubis and probably even to the symphysis, and actually probably to the opposite body, the opposite pubic body. But most of these fibers actually just interweave with the ones from the left side and don't have any bony attachment at all. So they just form a muscular tendinous sleeve around the trunk without a bony insertion, these fibers. Now, this external abdominal oblique aponeurosis has a free lower edge, and the free lower edge of the external abdominal oblique aponeurosis is called the inguinal ligament. The word ligament in anatomy can mean almost anything. You know about the ligamentum arteriosum, which is a degenerate ductus arteriosus. And that word ligament then refers to that structure. This time the word ligament is referring to the lower edge of the external abdominal oblique aponeurosis, to nothing more than that lower edge. If you make a parasagittal or sagittal section through the aponeurosis of the external abdominal oblique muscle, you will see that here is the aponeurosis, and then that lower edge curls under itself. And that is one of the reasons it gets a special name. It's an undercurled lower edge of the muscle, and that, in fact, by clinicians or by surgeons who operate in this region, is referred to as the shelving edge of the inguinal ligament, that part which curls around on itself to make a little kind of J in sagittal section. So we have an inguinal ligament, a lower edge, and for much of its extent, it curls under itself and has this thing called the shelving edge. There is a hole in the external abdominal oblique aponeurosis just superior to the inguinal ligament. That hole is called the superficial or the external inguinal ring. It exists because the gubernaculum was there when this aponeurosis formed out of tissues in the anterior abdominal wall. I drew it as now I'm going to tell you something, and I want you to forget it. I drew it as a nice single little hole there for passage of the gubernaculum. In reality, it's sort of a triangular hole, Some books refer to the aponeurotic fibers which form the superior border or the superomedial border of that triangle as the medial or superior crus of the external abdominal oblique aponeurosis. Some people refer to the part of the inguinal ligament which forms the infralateral boundary of that triangle, the inferior or lateral crus of the external abdominal oblique aponeurosis. I never use those terms. No one in this course ever uses those terms. But you may read about it. One term I do from time to time use, however, is the bridging fibers called the intercrural fibers. So if you didn't know that there were these two crura, you wouldn't have any idea why they're called intercrural fibers. But as far as you need to be concerned, we will never use the term medial crus of the aponeurosis and lateral crus of the aponeurosis. We'll just say there's a nice hole left around the gubernaculum there. The lowest part of the inguinal ligament, that shelving edge fibers, they sort of unfurl and gain attachment to the crest, to the superior ramus of the pubis lateral to the pubic tubercle. So this is really an unfolding or uncurling of the shelving edge, and those fibers gain attachment to the superior ramus of the pubis here. That is something you do need to know. It's called the lacunar ligament. It's just part of the inguinal ligament, really, but it gets its own separate name, and it's called lacunar ligament. This space, which I've called the retroligamentous space between the lower edge of the external abdominal oblique and the hip bone, I've called retroligamentous because this is a two-dimensional picture, and if you go and look on the skeleton and you draw a line between the anterior superior iliac spine and the pubic tubercle, which is the path of the inguinal ligament, that line will be in front of the bone. It won't be, superior to it as I've drawn it here. It will be mainly in front of the bone. So this space is really behind the inguinal ligament in a real three-dimensional person, so I've given that name, retroligamentous space, not infra. That's filled with a bunch of stuff. There's a bunch of stuff which passes out of the abdomen into your lower limb by passing behind the inguinal ligament, by passing behind the lower edge of the external abdominal oblique aponeurosis. One of those things is a muscle called iliopsoas. And the iliopsoas, like every good muscle, has fascia. And where the fascia of the iliopsoas meets the inguinal ligament, those two are bound together in what's called an iliopectineal arch. So in fact, there is no shelving edge right here. At this point, the lower edge of the aponeurosis is connected by strong fibrous connections to the fascia of the iliopsoas, and there is no shelving edge. The shelving edge really runs from this point down to the lacunar ligament, and then because it unfurls, it disappears in the region of the lacunar ligament, because that is just the edge having unfolded. The next layer in, corresponding to the chest's internal intercostal muscles, is the internal abdominal oblique muscle. The internal abdominal oblique actually arises from the iliac crest, and it arises from the iliopectineal arch. It arises from the thickened fascia of this iliopsoas muscle, thickened by its blending with the lateral part of the inguinal ligament. Lots of times you'll see this a lot, where fascia gets thickened where muscle attaches to it. This is called the iliopectineal arch. The iliopectineal arch gives rise to fibers of the internal abdominal oblique. The internal abdominal oblique is a very complex muscle in terms of fiber direction, whereas the external just ran downwards and medially. The upper fibers of the internal abdominal oblique run supero, or upwards and medially. The fibers that arise from the zone of the anterior superior iliac spine and the proximal part of the iliopectineal arch travel straight transversely. And the fibers that arise from the more inferior part of the iliopectineal arch curve downwards. So its fiber direction changes dramatically as you go from the top part of this muscle to the bottom part of this muscle. Regardless, all these fibers eventually give rise to a flat tendon called the internal abdominal oblique aponeurosis. The lowest most fibers of the internal abdominal oblique aponeurosis, from the downward arching muscular fibers, attach to the body of the pubis. just deep to where the external abdominal oblique aponeurosis attaches to the body of the pubis. Most of the fibers, however, just blend with fibers from the opposite muscle and don't have any bony insertion at all. The space here, there is a space because of the way this arches. There's a gap between the inguinal ligament and the lowest most fibers of the internal abdominal oblique, and I call that the inframuscular gap because it is genuinely below the muscle of the internal abdominal oblique. There's a hole in the lower edge of the muscular fibers of the internal abdominal oblique. That hole exists because the gubernaculum existed as this muscle was being formed. Middle inguinal ring, this is not a real name. Every time you see quotes, it means I made it up. This hole exists, and I call it the middle inguinal ring. The one that was in the external abdominal oblique aponeurosis is a real name that everybody uses, external or superficial inguinal ring. This hole, nobody refers to but me. It exists because the muscle formed around the gubernaculum. The deepest of the three muscles of the anterolateral abdominal wall is the transversus abdominis, corresponding to the innermost intercostal and transversus thoracis muscles of the chest. So there's 3 layers of muscle in the chest, 3 layers of muscle in the abdomen, and they have homologies to one another. The transversus abdominis muscle arises from, in fact, the thoracolumbar fascia. Some ribs arises from thoracolumbar fascia. The details, you can read about them in core or any book. The details don't concern me very much. And some arise from the iliac crest, and they run transversely, by and large, to give rise to their aponeurosis, which is the aponeurosis of the transversus abdominis. Some of the fibers also arise from the iliopectineal arch, but not over its whole length, not as extensively as the internal abdominal oblique fibers. And the lowermost fibers of the transversus also arch downwards. So although most of it is transverse in direction, the lowermost fibers of the transversus abdominis parallel but lie deep to the arching fibers of the internal abdominal oblique. So in that region right here, internal abdominal oblique and transversus run the same direction. Therefore, when you, in your dissection, are asked to find the transversus abdominis, the most foolish thing to do would be to try and cut through the internal here and look for the transversus deep to it. Because when fibers run in the same direction, you don't know when you're through one muscle into the next. The smart thing to do would be to make a cut up here in the internal, above the iliac crest, because there the internal is running 45 degrees upwards, and the transversus is running purely transversely, and you will easily see when you pass beyond the internal to find the transversus. Transversus has an inframuscular gap as well. There's a gap between its lower edge and the inguinal ligament, and that gap is bigger than the gap of the internal abdominal oblique because the transversus does not have as extensive an origin from the iliopectineal ligament arch, iliopectineal arch. So we have, and there is, in fact, no hole in the transversus for passage of the gubernaculum because the gap is so large that the gubernaculum and the muscle never formed around it. The muscle just bypassed the gubernaculum, just arched over it. And therefore, there is no hole in the transversus for passage of the gubernaculum. There is no inguinal ring in this muscle. Now, in some people, there's a reason I'm going to tell you this. In some people, some of these lower aponeurotic fibers of the transversus peel off from those that go to the body of the pubis and, in fact, attach to the superior pubic ramus lateral to the pubic tubercle. Not very many fibers often. These fibers don't have an official name. They're called good stuff they used to be called good stuff by inguinal hernia surgery because in the old days, surgery to repair an inguinal hernia was called an anatomic repair. You would go in, you would identify each layer, external layer, internal layer, transversus layer, and suture it to an appropriate structure to close up the hernial sac. The anatomic repairs are hardly ever done anymore. Now when you're repairing inguinal hernia, you just stuff a bunch of Dacron in there and it scars over, and you have to worry whether you've identified the different muscular layers or not. But it's called good stuff because it would hold a suture. If you had that, they liked it. People who did anatomic surgery because it would hold a suture, because it would be thick, have some thick tendon fibers in it. So that's why it got its name by them. But now, to go beyond that, in some people, you have these few aponeurotic fibers which could hold a suture. In other people, 10% of all human beings, this is really quite well pronounced. And you have a very thick sheet of aponeurotic fibers of the transversus, which attach lateral to the pubic tubercle. And that does get a name that even surgeons refer to, called the falx inguinalis. If you don't have it, you don't have a falx inguinalis. If you do, you do. 10% of people have it. A third of the people who have a falx inguinalis also have some fibers from the internal abdominal oblique, which pass and attach to the superior ramus of the pubis, lateral to the pubic tubercle, and therefore join those fibers of the transversus which do that. And if you have a tendinous sheet derived from both of these muscles, you are said to have a conjoint tendon. That's only 3% of all people have a conjoint tendon. I find this interesting because I don't know what the current dissector tells you to find. But certainly in past editions of the dissector, it always said, find the conjoint tendon. And before I knew this actually, and I learned about this from reading a book on inguinal hernia surgery, I believed every other text that said, everybody has this thing called the conjoint tendon. So I would go from table to table and I'd say, show me the conjoint tendon. And you wouldn't be able to do it. And I'd say, you people don't know how to dissect it. In fact, you people knew exactly how to dissect. I didn't know that it hardly ever exists. All right? So don't worry if the book tells you to find a conjoint tendon. Don't worry if you can't find it, because it only exists in 3% of people. All right. A lot of detail in there. If you're going to be a general surgeon, you have to know that stuff. The deepest layer of the anterolateral muscle and fascia of the abdominal wall is the transverse salus fascia. All right? It attaches to the crest of the ilium. It attaches to the pubic crest. It attaches to the inguinal ligament. And it lies deep to the transversus abdominis. There is a hole in the transverse salus fascia called the deep or internal inguinal ring. That everybody uses that terminology, and it exists because the gubernaculum pre-existed and the fascia formed around it. And finally, in this retroligamentous space, this space between the inguinal ligament and the hip bone, not only lies this iliopsoas muscle, but some really important things which are passing out of the abdomen and out of the abdomen and pelvis into the lower limb. One of these is a big nerve. You're never going to see that today, but we will see it in a few days, the femoral nerve. A giant artery called the common femoral artery, a giant vein called the common femoral vein. And then, because the transverse salus fascia it sort of extends as a sheath around these structures, which is called the femoral sheath, there's actually more space in that enveloping sheath than is needed for the femoral artery and femoral vein. So there's some fat and lymphatics medial to the vein, which is called fat and lymphatics in the femoral canal. That space medial to the vein is called the femoral canal. So I'll have occasion to refer to these a little later in the lecture. We're not going to be seeing that much today unless you cut much too deeply. But I will have occasion to refer to these structures and this fat and lymphatic-filled space medial to the vein that is between inguinal ligament and bone of the pelvis. So here are our three layers: external, internal, transversus abdominis, and then our deep fascial plane layer, the transverse salus fascia. And here's the superficial inguinal ring, just superolateral to the pubic tubercle in the external aponeurosis. Here's the made-up middle inguinal ring in the lower edge of the internal abdominal oblique. No inguinal ring in the transversus layer. And here's the deep inguinal ring in the transverse salus fascia, just superior to the inguinal ligament. If I could take a sagittal section through each of these inguinal rings, or in this case where the gubernaculum lies in relationship to the lower edge, I would develop the next diagram. Now, it's not possible to take a sagittal section through all of the inguinal rings because they lie in different sagittal planes. So we're going to pretend that I could take a sagittal section and squeeze those sagittal sections into one. And it would look like this. Obviously, you'd have skin and subcutaneous tissue of the abdomen, lower limb here. This would be the body of the pubis, more or less, right there. Here would be the first thing we'd see in our make-believe sagittal section through all inguinal rings is the external abdominal oblique aponeurosis with its inguinal ligament and the shelving edge of the inguinal ligament, and the hole here, which is the superficial or external inguinal ring. Then we would see the deeper internal abdominal oblique muscle with the hole through its lower edge, which I call the middle inguinal ring. Then we would see the deeper transversus abdominis muscle with no hole because it is arching over the gubernaculum. Then we would see the transversalis fascia with its hole called the deep or internal inguinal ring attached to the edge of the inguinal ligament here, and then this is where it continues as that sheath around the femoral vasculature that exits behind the ligament. And I've now completed this by putting in the peritoneum filled with fluid. I'm not drawing any bowel or anything like that in there. And the gubernaculum, which is running in the lateral extraperitoneal space around towards the front and then piercing the muscles and fascia of the anterior abdominal wall, attached here to the skin of the anterior abdominal wall, just above the pubis, and at the other end to the gonad. The gonad gets an artery from the aorta, sends and sends a vein back to the inferior vena cava. That I just labeled those gonadal arteries and veins. And in all early embryos, a duct called the mesonephric or Wolffian duct. I don't want to talk about it at this point very much. I just want to have it in here for the sake of accuracy. I will refer to it about 2 minutes from now, but don't dwell on it now. When you do your embryology, you'll learn a lot more about it. So this is the basic, sort of embryonic condition that I'm mixed with the adult that I'm trying to draw here. The gubernaculum, if this is going to become a woman or an infant girl, the mesonephric duct will be lost. It's a lost structure. So then we just have the ovarian artery and vein connected to the one pole of the ovary, which is what the gonad becomes, and at the other pole, the gubernaculum running to the skin with a little attachment to the peritoneal sac. This gubernaculum, if it's a girl, will start to contract and start to pull the ovary towards the deep inguinal ring. And it will pull out a little pocket of the anterior wall of the peritoneal sac. So here I've shown the ovary being pulled around in the lateral extraperitoneal space. This is happening, it's sweeping around the side, moving towards this deep inguinal ring, and a little pocket of anterior peritoneal wall being pulled out as well through the deep inguinal ring. That little tubular evagination of the anterior wall of the peritoneal sac is called the canal of Nuck. This continues to contract this gubernaculum. It pulls the ovary closer to the deep inguinal ring. It pulls out a longer tubular canal of Nuck from the anterior wall of the peritoneal sac, and inside that tubular evagination is fluid from the peritoneal cavity. And then, just as the ovary was about to get to where it wants to get, the deep inguinal ring, the uterus rises up and breaks the gubernaculum. Now, this is not really what happens. I mean, when you do your embryology, you may learn what really happens. But it's as if it developed this way, all right? The ovary is certainly true. One thing is absolutely true. The gubernaculum is split in two by the developing uterus. And when that uterus comes and splits the gubernaculum in two, this contraction here is not powerful to pull not powerful enough to pull the uterus anywhere. So nothing is moving after that. That's through. Then the gubernaculum just gives up, says, I can't pull this uterus, it's too big, I'm just going to stop. I'll pull the ovary down into the pelvis near the uterus, and then I'll give up. And that's exactly what happens. And at this point, the uterus will descend into the pelvis, pull the ovary down with it. I wrote names here, I better give you those names. When the gubernaculum is broken into two by the development of the uterus, the portion of the gubernaculum which now runs from the pole of the ovary to the uterus is called the utero-ovarian ligament. We'll see that in dissection when we do the pelvis. And the portion of the gubernaculum which runs from the uterus through the deep ring, through the middle ring, through the superficial ring, to attach to the skin of the labium majus is called the round ligament of the uterus. And that you will see today if you have a woman cadaver. You won't see it inside the pelvis. You won't see the part that attaches to the uterus today. But you'll see it coming out of the superficial inguinal ring and attaching to the skin of the labium majus, or at least going near there, because it tends to get very fatty and not so easily, the attachment's rarely seen. You will not see the canal of Nuck today, because as development proceeds, the uterus drops down, pulls the ovary into the pelvis, lengthens the round ligament, so it becomes a pretty long structure, and the canal of Nuck degenerates completely, and there's no remnant of it. Well, then why mention it, you say? To tell us something develops and then degenerates completely. It degenerates completely in almost all women, but not in all women. And women can present with cysts of this region, fluid-filled sacs of this region, which are persistent canals of Nucks, which have swollen with fluid. Not a common presentation, but if a woman presents with a bulge in the inguinal region, it's one of the things you have to consider, that it is a canal of Nuck cyst. All right? But most women, it degenerates completely, and they do not have, and are not at risk for developing these cysts. So that's women. Men. Men do keep the Wolffian duct or the mesonephrid duct, so they don't lose it. It, in fact, becomes the vas deferens. Men, that's what carries sperm from the gonad to the urethra. The vessels change their name to testicular artery and vein, but otherwise it looks like our female did. The gubernaculum contracts. Oops, sorry. Forgot about a big thing here that's developing. In women, you do not get a scrotum. You get the labium majus, or the two labia minora, which, and you'll learn about this in development, they do not fuse and form a scrotum. But in men, the two equivalent structures do and form this bulging outpocketing of the skin and subcutaneous tissue of the anterior abdominal wall, just above the pubis. I've shown one thing here is that the subcutaneous tissue of the scrotum is unusual in that it has some smooth muscle in it, a lot of smooth muscle in it. That's not typical for subcutaneous tissue, and as a result, the subcutaneous tissue of the scrotum gets a separate name called the tunica dartos of the scrotum. So I just want to put that in for the sake of completeness. Not necessarily relevant to the inguinal canal, it's just true. All right, so then the gubernaculum contracts in the male, and it starts to pull the testis towards the deep inguinal ring, and it starts to pull out its own little tube of anterior wall of peritoneal sac. In a male, this is called the processus vaginalis. It is the male's version of the canal of Nuck. The processus vaginalis and the testis are being pulled towards the deep inguinal ring. They actually reach the deep inguinal ring, but they're much too big to get through it. So the processus vaginalis, with the testis adjacent to it, pushes out a layer of the transversalis fascia in which the deep inguinal ring sat. And now this layer of transversalis fascia, which surrounds the gonad and the processus vaginalis, passes beneath the lower edge of the transversus abdominis towards the hole, which I have called the middle inguinal ring. They cannot fit through that. So as this continues to contract, it pulls out some muscle fiber from the internal abdominal oblique layer. And now we have a muscle fiber evagination surrounding a transversalis fascia evagination surrounding the gonad adjacent to the processus vaginalis of the peritoneal sac. They encounter the superficial ring through which they cannot pass, and therefore they push out a layer of fascia derived from the external abdominal oblique aponeurosis. And now, as this thing continues to contract, it pulls it all the way into the scrotum, and you've got a situation where you have a gonad with its vasculature going all the way back in to connect up to the central big vessels, the ductus deferens, all next to an evagination of the peritoneal cavity called the processus vaginalis, all surrounded by a tube of blue stuff, transversalis fascia, all surrounded by a tube of brown stuff, internal abdominal oblique muscle, all surrounded by a tube of gray stuff, the aponeurosis or fascia derived from the aponeurosis of the external abdominal oblique. For the sake of completeness, because if you dissect this testis, you will see that in fact it has its own connective tissue sheath called the tunica albuginea. So I just put that in today for the sake of completeness. The testis has this tough fiber sheath called tunica albuginea. The ovary does not have such a structure. All right, forget about it. Now, the tube which surrounds all of this stuff, derived from the external abdominal oblique aponeurosis, is called the external spermatic fascia. The tube just internal to the external spermatic fascia, which is derived from the muscle of the internal abdominal oblique, is called the cremaster muscle and fascia. It is actually a striated muscle, but the muscle fibers are fairly sparsely distributed, so there's a lot of fascia in between them. The tube that's derived from the transversus abdominis, which surrounds all of these things, not all of them, it surrounds the gonad, its vasculature, and the processus vaginalis, and the vas deferens, is called the internal spermatic fascia. The processus vaginalis is one of those things adjacent to the gonad, surrounded by all three of these tubular evaginations. It is still in open communication with the peritoneal cavity at this time in development. Where are the original inguinal rings? Well, I talk real fast, and this is, I've done this so many times. For me, it's like I was in. This is a very strange thing about anatomy, and I'll tell you this: you're learning lots and lots of words. There will come a time when you won't understand or believe that you didn't know these words from the day you were born. Vagus will become a word that is so used by you that you won't be able to remember a time you didn't understand the vagus or the LAD or any number of things, main stem bronchi. I got news for you. This is complicated. There'll come a time when you'll say, I knew that always. It's just obvious. It had to be this way. All right, come on, you have to be brave. When you sit in front, you have to be brave. I just want to ask you this. Where are the original rings, the very first things that I called superficial inguinal ring, middle inguinal ring, and deep inguinal ring, through which the gubernaculum passed? Just point to them with, listen.
Oh, is this a pointer?
Just point. You got to find holes through which the gubernaculum passes. The original holes through which the gubernaculum passed.
Yeah.
No, that's not the original hole through which it passed. No, that's a bone. That's the shelving. That's sort of the shelf. Those are big holes up there. All right. Pass it to your neighbor. She knows.
He told me.
I don't care who told you. That's right. Point to it again so everybody can see it. Those are the original holes through which the gubernaculum passed. Who told you? Josh did? All right. He gets credit for it. All right. These are the original holes through which the gubernaculum passed. Here's the original superficial inguinal ring there. Here's the original middle inguinal ring. Here's the original deep inguinal ring. They're stuck now in the bottom of the scrotum somewhere. These things up here, now you have a very large hole in the external abdominal oblique muscle to which is attached the external spermatic fascia. You have a very large hole in the internal abdominal oblique to which is attached the cremasteric muscle and fascia. And you have a very large hole in the transverse salus fascia to which is attached the internal spermatic fascia. All right? In fact, in reality, these large holes are what we call, in the adult male, superficial and deep inguinal rings. We change the name now and say, these are the rings here. Here's the big superficial inguinal ring of your adult. Here would be the big middle ring, if anybody ever used that term. And here's the big internal ring of your adult. So we forget the fact that the original rings, the ones that correspond to the women, are down here in the scrotum. In women, they're still up where they were supposed to be. Where they were embryologically, there's been, because the round ligament just goes through these rings without pushing out big sacs in front of it. And, but in men, the homologous structure is in the bottom of your scrotum. Now, the processus vaginalis separates normally from the peritoneal sac and separates from a little sac that is adjacent in contact with the testis. So I've indicated a separation here and a separation here and a little faintness of the color because that middle segment of the processus vaginalis gets fainter and fainter and disappears, like the canal of Nuck did, usually does. And now you've got the definitive condition. You've got something which is called the spermatic cord. The spermatic cord, by definition, is the external spermatic fascia surrounding the cremasteric fascia, surrounding the internal spermatic fascia, surrounding the vasculature of the testis and the duct and the vas deferens, and no processus vaginalis, but a little, well, now that is a spermatic cord. These three layers surrounding the vasculature and vas deferens that go to the testis. Down at the bottom, I guess, where the spermatic cord expands, we don't tend not to call it that down here, where the testis actually exists, is a remnant of the processus vaginalis, a real peritoneal sac derived from the peritoneum of the abdominal cavity, which is now stuck in the bottom of your scrotum. When I say your scrotum, I don't mean half of your scrotums. Which is called the tunica vaginalis testis. It's actually very important. It gives the testis mobility in the scrotum. So because that's what, because it's a fluid-filled sac that the testis is adherent to and can move without getting into problems down there. Now, this is really what the lecture is about here. Hernias. Hernias, as I told you, are pushing out through body wall where you shouldn't push out. There are three kinds of hernias of this region of the groin. One is called the indirect inguinal hernia. Now, despite the fact that this inguinal canal passes obliquely through the anterior abdominal wall so that it will minimize the chance of something passing through the deep ring, going the length of the canal and getting out the superficial ring, it doesn't always work. And an indirect inguinal hernia is a hernia that passes exactly through the path of descent of the testis. It goes right through the same path that the testis was pulled through. This is called descent of the testis. I didn't say that, but it is. The path that the testis was pulled through, or if it's a round ligament, follows the path of the round ligament out of the abdominal cavity into the subcutaneous layer. So an indirect inguinal hernia goes through a deep inguinal ring, a quote-unquote middle inguinal ring, and a superficial inguinal ring, and in a male can easily work its way down into the scrotum. And it will be a sheet of peritoneum with bowel pushing out behind it, passing through those rings and down into the scrotum. In a woman, it would be a piece of peritoneum with bowel, sometimes, not always, passing through the rings towards the labium majus. But because the rings, well, we'll see in a second. That is what an indirect inguinal hernia follows: the path of the round ligament or the path of testicular descent. A direct inguinal hernia. This is not due to the weakness provided by the inguinal canal, the weakness in the abdominal wall caused by the existence of an inguinal canal. It is due to the fact that there is this thing called the intramuscular gap, which is a weakness in the abdominal wall due to the fact that the internal abdominal oblique and transversus abdominis have arching lower borders. But the weakness of a totally different reason. In a direct inguinal hernia, bowel pushes, and peritoneum covering it, pushes transversalis fascia underneath these gaps. The bowel and peritoneum then reach the deep surface of the external abdominal oblique aponeurosis, where they may be stopped and just called a bulge there, or if you're unlucky, they can turn medially, head down towards the superficial ring, and exit the superficial ring, and present pretty much like an indirect hernia. Indirect hernias have to come out the superficial ring. They have to do it if they're big enough, because they're following the path of testicular descent. They're following the path of the round ligament. A direct inguinal hernia, often because it's hard for it to make the turn and then get to the superficial ring and get out again, may just present as a bulge in the anterior abdominal wall, much more likely to do that than it is to exit the superficial ring. That means indirect hernias are much more likely to end up in your scrotum than is a direct hernia, which finds it hard to navigate the turn to get out of the superficial ring. Not impossible, just hard. That's what a direct inguinal hernia is. The weakness caused by the weakness due to the arching fibers of internal abdominal oblique and transversus.
Professor?
Yes?
Was that the direct or indirect?
Direct. Doesn't make sense, does it? The nomenclature, always my whole life, I've always thought, gee, they should call the one that goes through the path of the inguinal canal the direct one, but it's not the way it is. That's called the indirect one. This is called direct. That is the way it's called. So I didn't make a mistake, though. I'm glad you thought I might have made a mistake, because it points out that I didn't. All right. So, no, that's it. Indirect follows through the canal. Direct doesn't. Indirect hernias, they will begin their herniation at the site of the deep ring right here. Direct hernias begin their herniation medial to the deep ring. They don't go through it, they actually begin medial to it. Clinicians refer to the space between this artery, which you will see today, I think. If not today, then tomorrow. This artery is called the inferior epigastric artery. It arises from the parent of the common femoral. The parent of the common femoral is called the external iliac. So there's an artery that arises from the parent of this vessel, passes up behind there, posterior to the inguinal ligament, deep to it, medial to the deep ring, and then runs and supplies the rectus abdominis muscle, this muscle here. Direct hernias start medial to the ring and medial to the inferior epigastric artery. Indirect hernias start lateral through the ring, but lateral to the artery. This space between the inferior epigastric artery, the inguinal ligament, and the lateral edge of the rectus abdominis is called Hesselbach's triangle. There is no anatomic name for it, but I know every surgeon in the world calls it Hesselbach's triangle. And its only significance is it's where you find a direct hernia. Indirects are not going through Hesselbach's triangle because they're starting lateral to it. The final hernia of this region is not an inguinal hernia. It has nothing to do with the rings, has nothing to do with weaknesses of or arcs of the muscles in this inguinal region. It's just another hernia in your groin that can be confused with an inguinal hernia at diagnosis. A femoral hernia relies on the fact that a structure can push out through this fat and lymphatic occupied space medial to the common femoral vein. So that kind of hernia pushes out behind the inguinal ligament. Does not put, these other two come out above the inguinal ligament. This comes out behind the inguinal ligament. It is called a femoral hernia, and it relies on the weakness due to the fact that this space here between the vein and the rest of the femoral sheath is just occupied by fat and lymphatics, which don't resist very much things passing through them. Now, of these three types of hernias, which can present in the groin region, two being inguinal hernias related to the inguinal canal, or at least the structures that form it, and one being unrelated to it, called a femoral hernia. If 100 people walked into your office with a hernia, this is what you could expect. You don't have to memorize this. This is what you expect the distribution to be. I'll tell you what you should know from this chart. If 100 people walk into your office with a hernia, you can expect that 89 of them will probably be men. Hernias are much more, these kinds of hernias of the groin are much more common in men than in women. Of the 89 that come in who are men, the preponderance of those will have indirect inguinal hernias. And that, we presume, is because the rings are so much enlarged by the descent of the testis and the processus vaginalis that they are just too big to always be closed by this flap valve mechanism, the deep ring in particular, too big to be closed by the flap valve mechanism, and therefore men are far more predisposed to an indirect inguinal hernia than to any other kind. They are far more predisposed, obviously, than women, because of the 9 women who come with hernias, even though the majority are indirect in women. It is the most common hernia in women, an indirect inguinal, because that path through the canal is still the easiest path for something to get out of your abdominal cavity. It is much, much less common than in men because those rings have not been dilated by testicular descent. So what you have to know is the most common type of hernia in both men and women is indirect inguinal. Men have it many, many times more than women do. So I expect everybody to know that, those two things. The most common in both, indirect inguinal, men far more than women because of testicular descent and the enlargement of the rings. Direct inguinal hernias. Here I would expect you to know that they are essentially unheard of in women. And no one really knows why they're unheard of in women. Used to say women have more good stuff. Sounds all right to me, all right? Good stuff narrows the intramuscular gap and makes it smaller, and therefore would make the direct hernia less common. That may be true. There may be some other anatomic consideration. It has never been known for sure why they are so uncommon in women, but they are. They are obviously, 100, not 100-fold, but near 100-fold more common in men. It's either because men don't have enough good stuff, or because, at least in our society, most of the heavy lifting is done by men. And direct hernias tend to occur in older men doing stuff they shouldn't be doing. When you get older, your connective tissue just gets crappy. And not that I would know, right? Your connective tissue just gets weaker. The collagen is not as good. Nothing is as good when you get older. And if you still go about lifting heavy things, your muscles get weaker too, including because normally what prevents a direct hernia is contraction of the internal abdominal oblique and contraction of the transversus closing the intramuscular gap. When those muscles contract, they pull their lower edge down and close that intramuscular gap. If those muscles are weak, and if the transversalis fascia is weak, then in fact, you are just going to get a direct inguinal hernia. And so as you get older, if you still engage in very heavy lifting stuff, you are predisposed to getting a direct inguinal hernia. So that's probably one reason men have them so much more than women. In terms of indirects, I will say one other thing. Directs tend to occur much more in older men than in younger men. Indirects tend to occur in newborns, and in fact, virtually much more obvious, come back to English. If you have a hernia in a newborn, it is almost certainly going to be an indirect. Number one, they don't engage in any heavy lifting. Number two, in lots of newborn boys, the processus vaginalis is delayed in its degeneration or doesn't degenerate. And if you have an open processus vaginalis leading from your peritoneal cavity down into your scrotum, you are simply just begging for an indirect inguinal hernia. So there are actually, many, many times, there's no such thing as a direct inguinal hernia, essentially in a newborn. If you see a hernia in a newborn male, it's almost certain it will be an indirect inguinal. So I expect you to know the predisposition of newborn males to indirect inguinals, and the great rarity of directs in women. And then the final thing I would expect you to know is that for once, men are better off than women in that men get fewer femoral hernias than women do. And the reason this is believed to be is that if we go back to this drawing here and realize that the femoral hernia comes through this space, we're talking about a space between the inguinal ligament and the bone of the pelvis. Normally that space is filled with muscle and vessels and fat. Women have a woman of the same muscular build as a man will have a larger distance between the anterior superior iliac spine and the pubic tubercle because of the way the pelvis is structured for birth. Women have a different shaped pelvic bone to promote delivery of the child. So if you have a woman of the same muscular development as a man, this distance between the anterior superior iliac spine and the pubic tubercle will be greater. Or expressed differently, if you go out and look at two people who have the same distance between the anterior superior iliac spine and the pubic tubercle, the woman will have smaller muscles than the man will. As a result of the space here, the retroligamentous space, in a woman, the amount devoted to the femoral canal is larger, relatively larger, than in a man. So women are, for that reason, predisposed relative to men to have more femoral hernias. And in fact, femoral hernias are more common in a woman than a direct inguinal, whereas obviously femoral hernias in a man are less than a tenth as common as direct and hardly ever compared. So you should know that women do seem, to a certain extent, predisposed to femoral hernias, certainly more so than a man would be, and it actually is the second ranking hernia in a woman of this region. So it's a lot of stuff to go through, obviously.